Hello, and welcome to our first research discussion on one of the research projects that we've done on lateral ligamentous approach for the talar body fractures. I will first show the presentation done by one of our old registrars, Laura-Ann Lambert, at the British Orthopaedic Association this year. And then we'll discuss with some of my collaborative authors, Mark Davies and Jit Mangwani.
Adequate perpendicular access to the talus for treatment of talar body fractures, peripheral talar fractures, and the open repair of osteochondral defects is difficult. Multiple approaches have been described that often require dual incisions and, in some circumstances, fibular or medial malleolar osteotomy. With the Liverpool Foot and Ankle Group, Sheffield Teaching Hospital, and the University Hospital Leicester, this is a study which assesses an approach to the talus called the lateral transligamentous approach. In this presentation, I will take you through the steps of the approach and the results of the perpendicular access to the talus that it provides. There are no conflicts of interest to disclose for the authors involved in this work. The aim of this study was to quantify the percentage talar body accessible via the transligamentous approach. Limitations of access with all approaches to the talus are well described. With any approach, the goals are to preserve blood supply, respect the soft tissues, and achieve adequate visualization so that you can achieve your endgame: open reduction and internal fixation with congruent articular surfaces. This paper was published in 2019 in FAS by senior author Mr. Callum Clark of Heatherwood and Wexham in conjunction with the University of Barcelona. In this study, they assessed standard soft tissue approaches to the talus and cadaveric specimens and subsequently assessed the orthogonal access with a surgical instrument. So shown here is the 24% access to the talar dome with a standard anterolateral approach. This is not the classical sagittal approach following the lateral side of the extensor digitorum longus, but the Ollier approach. Perils on the lateral side do include the perforation branch of the perineal artery and the artery of the tarsal sinus. Shown here is the anteromedial approach, in which there is access to the talar dome of approximately 24%. The medial talar neck branch is at risk, as well as the artery to the tarsal canal, which can be in jeopardy if dissection occurs or plantarward on the medial aspect. With the posterolateral approach, only 7% of the talar dome is accessible. And lastly, with the posteromedial approach, only 5% of the talar dome accessible. So shown here is Elias et al. FAI 2007, this 9 grid, which divides the talus into zones 1, 2, and 3, anterior, 4, 5, and 6 central, 7, 8, and 9 posterior, with medial and lateral aspects respectively. This is a reproducible grid and has been used in Malagaleda's paper to show that in all access is limited. Their hatched red lines show all approaches, and it was found that 39% of the total talar surface is not perpendicularly accessible, which is very much supported by current literature. This is another paper, earlier work by Dawson et al. In a cadaveric study out of Salt Lake City and Iowa City that concluded on average 17 and 20% of the medial and lateral talar dome could not be accessed without an osteotomy. Furthermore, a residual 15% of the central talar dome remained inaccessible even with osteotomies. All in all, they found that 37%, similar to Malagaleda's 39%, of the total talar surface is not perpendicularly accessible via soft tissue surgical approaches. So what did we do? We performed a cadaveric study on 10 specimens demonstrating our technique to 6 foot and ankle surgeons previously inexperienced in the same. An incision was made on the anterolateral aspect of the ankle, anterior to the fibula, extending towards the third metatarsal base. The superficial perineal nerve was anterior to the incision and retracted. The extensor retinaculum was incised. Both ATFL and CFL were taken off their fibular insertion. A bone lever was then placed behind the lateral aspect of the talus and levered forward with the foot in equinus and inversion. The slide shows deep dissection showing the PTFL, which prevents full translation of the ankle, after ATFL and CFL are incised. So what did we see? All in all, mean percentage area of the talar dome available through the lateral transligamentous approach in 10 specimens was 77.3%, with a 95% confidence interval of 73.3 and 81.3. In all specimens, the complete lateral talar process was accessible along the lateral and dorsal medial aspects of the talar neck. We see again the grid of accessibility overlain on the 9-grid division as described by Elias et al. And FAI in 2007. Accessibility to each zone within the grid with a perpendicular surgical blade was documented. ImageJ software was used to calculate the surface area used with the lateral transligamentous approach for each specimen. So as we can see here, the zone 1, 2, 3, 5 and 6 have 100% accessibility. Zone 9, 80% accessible with the LTL approach. Zones 4 and 8 with more limited accessibility, and zone 7 is inaccessible. This is an overlay of all 10 specimens showing the inaccessible region in black, and the remainder of the talus or the talar dome is accessible. So if we use here a comparison of the image of the study taken from Alagaleda et al. Mentioned at the beginning of this presentation, the hatch red lines show the areas accessible with the anterolateral, anteromedial, posterolateral and posteromedial approaches. When we use the LTL approach, when we take off the HFL and the CFL, we're able to fully access zones 1, 2, 3, 5 and 6, the majority of 9, and most of 4 and 8, with zone 7 not being accessible. The majority of the talar body is accessible with a single incision, and knowledge of this should influence your preoperative planning. Talar body fractures involve the articular surface extending into or posterior to the lateral process. This distinction is important as talar body fractures affect the congruity of the tibiotalar and the subtalar joint. The talus does receive a great amount of arteries from many different sources, and its position is in the center of a large vascular network. Our LTL approach should preserve the talar body blood supply by avoiding medial blood vessels and lateral blood vessels, but there is no clinical study been done on approaches and preservation of blood supply of the talus. Most importantly, the LTL approach is simple and reproducible. So in conclusion, the lateral transligamentous approach to the talus provides significantly greater access to the talar dome when compared to standardly described approaches. It is clear that the residual surface area that is inaccessible within this approach is predominantly in zone 4, but almost in its entirety in zone 7, which represents the posteromedial corner of the talus.
So thank you for all joining us. This is the first collaborative research we talked about. I introduced both my esteemed colleagues, Mark Davies from Sheffield and Jit Mangwani from Leicester. And thank you for joining me on this.
Thank you, Lyndon.
Yeah.
Thank you.
So the research was presented in BOA this week, and it went down very well, and also it was presented in BOFAS last year, claiming 3rd prize, and a lot of the questions that came from it were not based on the science of the project, but actually more on the use in clinical activity. So one of the greatest bits of this, I think, is to show some cases that we might have used this in and how it's been helpful for these cases. And certainly it's my workhorse now for talar body fractures. So did either of you use this before we started discussing it? I certainly kind of came across it due to a patient having the ligaments off already.
Yeah.
Yeah, I think, go on, Jit, you go first.
No, that's fine. So I had exactly the same situation, a very young patient who presented, and I'll show you the case in a bit, where I just stumbled across both the ligaments off on the lateral side as I opened and found that, once I reduced the fragment back, which I'll show you in a bit, again, the exposure achieved was phenomenal. So that's where I think I said to you, Lyndon, at the time, have you thought of it? And you said exactly the same thing. I've come across it as well. So it was a chance finding, as they say.
Yeah, and I'll again, similarly, the case that I came across it, I'll show as well. And yourself, Mark?
Yeah, well, I think one of the reasons why I'm on board with the project was that I presented a talk on Talus approaches on a course that we both taught on, and it just seemed to me that you were looking at my slides thinking he's thinking and doing the same thing as me. And I stumbled across it fairly serendipitously at the same time. And one of the cases tonight is that case, but the other one is one that I've done similarly since, and it works. It's great.
Fantastic. Okay, so we'll jump straight into the cases. That's all right. All right. So I'll quickly run through the cases from my side, and then each in turn we can go through the cases that we found useful for. So this was the case that I was saying that I stumbled across it. So I remember my fellow at the time, Eric Swanton, who's now a consultant in New Zealand. I remember him saying, well, how are we going to get this body fragment? Because if you look at this, we had this large lateral shoulder of the talus that we needed to get to, as well as to visualize the reduction of this body. And I remember saying to him that, well, the ligaments are off, and let's go in this side and see whether or not we can get to it just through the ligaments. And it's by putting a Homan around the back of it to try and reduce the talus onto the posterior facet, you could then, it was quite obvious, you could bring the talus almost out and rotate the talus out to get this visualization. And it was, this chap now is a good 4 years down the line, done very well. And in this case was back last year, kind of a log split injury. A chap fell off scaffolding. It's an open fracture. You can see the air within the on the CT here, and this big log splitter. But you can see the distance from the fibula to the talus, and the ligaments have obviously been pulled off with that. And this one was another one that, as soon as you were in there, and the wound was actually over where these ligaments were, so it had chosen itself as an approach.
Lyndon, can I just go back to the first case? Is that all right? Yeah. The first case, I've got a case that I did years ago, and it's almost identical set of fracture patterns, very much two separate fragments of the posteromedial and posterolateral talus. And in my naivety of about 10 or 12 years ago, I did the case prone and did a posteromedial and a posterolateral approach. And your x-rays are much better than mine. And it certainly was the hardest talus I've ever fixed. And I'm sure that was partly because of my approach. And actually, to me, the key thing is that little avulsion off the fibula. And I guess that almost is a telltale sign on your plain film that maybe would direct you to consider using the transligament approach. And that, that should hopefully be the sort of light bulb moment that says to a potential surgeon, let's go for it from a lateral approach rather than the way I did it, which was to try and do it from the back, which was difficult but doable.
Oh, certainly, Mark. I certainly stumbled across this, and looking at how I would have taken this if I hadn't had that, well, a sort of lucky noting on that avulsion, I probably would have tried to do a fibular osteotomy. And I must say, the fibular osteotomies I've done in the past, I'm never really happy with the exposure.
No, it's never very good, is it?
Yeah. Same here. I would say, the approach we're describing actually gives a lot more of the talus exposure, and without the hassle of doing the fibular osteotomy and taking it down and getting into the joint becomes a big faff.
Yeah, I agree. So then it was a easy fixation. He did have a postural medial fragment which wasn't fixed at the time. That has actually healed up, but I do find that you obviously can't get to this postural medial side, and that does negate a separate incision. This was the one from a little while ago. You can see the mess of the midfoot. It was a polytrauma, someone fall from height. And you can see this posterolateral corner. I've taken the fibula out on this picture. You can see like it's right underneath the fibula for you to get to it. And for this one, you can also see the ligaments are already off, like you were saying earlier, Mark. Mm. So that's the telltale sign. So by bringing this forward, I was able to get underneath the fibula. I repaired it back with anchors rather than a screw on this one. I had also other injuries distally, and also a tibial shaft fracture, as well as other injuries. But he's done very well in regards to this bit he could fix back. And the screws, you can see, that was underneath the fibula, which is very difficult to get to unless you're doing a fibular osteotomy. And I've had this case recently where you can see the large osteochondral injury, and it's actually sitting here anteriorly. Yeah. You also had a fibular fracture. But I found even trying to go through the fibular fracture wasn't satisfactory because I had to get to this anterior aspect anyway, because that's where the fragment was. And this is where you can see this the bony aspect of this chondral injury. And again, by bringing that forward, and I did hinge it as well back on the distal fibula, I was able to get underneath the fibula and get this chunk back and fix the fibula then, obviously. But this one was a transligamentous approach. So I do find them just really useful.
What's also is clear from all of this is that if you look at the literature and you look at papers that are describing how to deal with body fractures, it's very clear when you look at the x-rays that are in those papers that people have really struggled to get hardware well positioned into the body because of the difficulty with the surgical approach. And what's common to all four of those cases is that you've been able to get a neat little reduction and really very minimal lag screw fixation almost across the board in order to achieve your reductions. And that's been my experience of using this technique. I think that's because you have a good exposure. Otherwise, everything is challenging. You can't get the angles right to get your reductions. K-wires end up in the way. You know, you wish you're using sort of dissolvable K-wires in some instances, and you can just cut them flush. It's really very tricky. But your fixations have shown that actually it can't be tricky because you're getting decent, simple lag screw fixation.
Yeah, no, these were relatively straightforward from cases that prior to this I very much struggled with.
Yeah.
Yeah. So they were the cases I wanted to illustrate the point. These are your cases from for you, Jit.
Yeah.
You want to talk
so this is a young patient who had a fall from a climbing wall, and as you can see, you've got a body fragment, and pretty much all of the subtalar joint is all dislocated. Here you don't have the telltale sign that Mark was talking about earlier on, and looking at it is obviously quite tricky. I was thinking where to go from, and in fact, the colleague who was on call tried to put an external fixator on, so there should be a picture next, and try and reduce it with sort of ligamentotexis indirectly. Which unfortunately wasn't successful. As you can see, the fragment is still out, and the part of the talus is still sitting outside of the mortise. So took the patient back to theatre, and as Mark was saying, it's your light bulb moment when I thought, which approach am I going to go from. When I opened on the lateral side, you'll see the next picture there. Sorry, this is just the CT scan, so shows clearly that the subtalar joint is dislocated pretty much, and the fragment is sitting out of the mortise completely. But when I opened it up, I realized that the ATFL completely gone off. And interestingly, the CFL in this case was peeled off from the os calcis. So it wasn't from the fibula itself. It was actually from, as you can see, the anchor. It was from the os calcis. So having reduced it reasonably well, I would think, and fixed it with some screws, I repaired the ligaments back, and I tested the ankle on table, and it tested pretty stable. So I was reassured that I've not, left the ligament sort of unstable, with an unstable, a young patient with an unstable ankle there. So the next one should show a CT, I think, over a year. Yes, there's obviously, you can see the ankle is reasonably congruent, fracture's completely healed, and patient's pretty much back to normal level of activity.
Well, this is an amazing result considering the injury this patient's had, where the talar spat out in that position. This, he's going to have arthritis.
Yeah.
10% of body fractures will have arthritis regardless, but this is just an amazing result considering the injury.
It means that further down the road, you've got so many more reconstructive options available to you, because you've got no loss of the talar body height. Your anatomy is roughly where it should be. It's literally millimeters out of kilter. And the problem is, with the old-fashioned ways of dealing with it, you often end up with screw heads in the wrong place that cause problems, etc., etc. So I think it's a very versatile approach. It allows you to do some fairly acute fixation, and the results are clear to see.
Yeah.
You also,
I've got an acute osteochondral fracture, which again, as you were showing, Lyndon, previously, it makes life much more easier. I fixed this with a smart nail rather than, I don't know, Mark, have you had some experience with those?
I've been using them for about 10 or 12 years, and in fact, I use those for any of the sagittal splits that go through the body, because of the way the profile of the head of the nails, that they sit nice and flush on the cartilage and they don't cause any trouble, and you'll never have to retrieve them again. So it's absolutely.
Oh, this is a great example of learning from each other. I in fact saw one of Mark's cases in the course he came down to Leicester to teach on, and that's what sort of immediately prompted me to think about smart nail, and obviously the approach that we just discussed. So it's just sort of learning from each other at all stages is what the message is here.
Yeah, no, I haven't used it. I must say, I sometimes, especially if you got a very little bone, sort of putting a headless screw underneath it is very unsatisfactory. So I'll look into that. It's a good call. To move on to yours, Mark.
Yeah, I've got two cases. On the face of it, this one doesn't look particularly interesting. It's a sort of the usual combination of neck and body at that junction, which can be really awkward to deal with. I think that I can't remember. I think this is a climbing injury from the Peak District in a young fella. It's a closed injury. I think the next one is a CT image. And that shows a little bit more going on, as often is the case with CT. The lateral process isn't right. You can see that the body's involved laterally. There's a head split, and then actually the body is a bit more comminuted when you're looking at it from the coronal plane. You can see the splits there. So this was somebody who I thought, well, actually, on when I look at it overall, what am I going to be able to do? Well, I think I can address the lateral side better. There's a bit of medial comminution. I think I can make the reduction better laterally. So that's when I did the transligamentous approach. And I think the next slide shows how I did that. Well, you can see, again, very minimal fixation. So I've been through the lateral approach. You can address the snowboarders element, if you like. And on the canali view in the middle there, you can see that there's that reconstruction of the lateral wall of the talus, and that's a very, very obvious contour that's there on the lateral side. And it also shows the medial comminution, which I kind of left completely undisturbed. And then a single screw that is lagging across the split in the talar head, all of which can be approached through that same incision. So that was, again, very minimal fixation, and he's back climbing, but I haven't got any of his post-op films. That's a few years ago. And then the next one is a road traffic accident in a chap who's about 60. And I haven't got the plain films before he went to CT, and it might very well be that he didn't ever have any. But you can see that the head of the talus is dislocated. There's a split in the body. The posterior facet is subluxated, and there's some comminution. Obviously, with 3D reconstructions, you could probably get more information, or scrolling through the images on your desktop at work, you'll find the information you needed. But again, I plan to do a transligamentous approach. This was the second one of those that I'd done. The first one I just showed you was the one where I had the sort of epiphany, and this one was where I thought, actually, now I know what I'm doing. I can use the fact that the ligaments have gone. So I think the next images are fluoroscopic images. So this showing the through a medial wire, but a lateral wire going through to the medial side. You can see that starting to reduce and make the talus look a little bit more talar shaped, having got the talar head back in joint, and the posterior facet relocated. And then the next set of images shows, so this again is that contour of the lateral process, which I've taken literally a hand plate here and molded it to fit that contour with 4 really rudimentary tiny screws from a handset that are binding the lateral part of the talus together, but they've done a good job. The TNJ is congruent, the posterior facet's pretty congruent, the ankle looks good. So the next thing I need to do is actually try and address the sort of medial side, the medial column of the talus. And I like to do that from the back through posterolateral approach. And of course, that's just really a very short stab incision near where the peroneal tendons are. Find the bare area of the talus, and then to get a wire across. And I think just biomechanically, it's a much more superior way of addressing the talus. And then I think I put a single screw across there, just literally to sort of counterbalance the medial column. And he has done okay. I think there might be a set of images at the end. No, I didn't upload them, but he's done fine. And I think really the tail of the tape seems to be these are fractures that historically have been said have got a dreadful outcome, but I don't think they do if you can get a good reduction and you don't further damage the blood supply to the talus by a clumsy approach. And this isn't a clumsy approach at all. So that's my bit.
Yeah, no, I agree. I've definitely gone down this line as well, Mark, having this lateral locking plate and then a buttress on the medial side. I think it works really well. And seen a lot of the guys from London are doing the similar approach. We all seem to be going down the same avenues independently, which is quite reassuring, I think.
Just reassuring.
It's always good to nick something from somebody else's set as well. So get a hand surgeon set to play with it is always a good thing.
Yeah, that's fantastic. So I realized that let me just come out of sharing for a second. just for us to kind of finish off. That's all right. I'll edit this a little bit out. Don't worry about that. So the last thing I want to say about, because the last question a lot of people are asking, okay, well, you've taken the ligaments down. Do you have any problems with the ligaments healing? Well, what do you think, Mark?
The answer is no. Just in the same way as when you have a horrendous elbow fracture and you pull it all apart and you put it back together again, you don't ever see unstable elbows. These things stiffen up, and the same is true around the ankle. No, I don't, but Jit very nicely showed that he's reattached some of them, and I do the same if you can. There's no harm in doing that.
Yeah, I find the same, because in my hands, the rostrum is one of the procedures I'm pretty happy with. Much more than an osteotomy, anyway, in my hands. What do you think, Jed?
Absolutely agree, and obviously not done hundreds to say we've never had a trouble, but the ones that I've seen and done, there's no issue with the instability at all. As Mark was saying, obviously naturally they're going to stiffen up a little bit, and as you were saying, rostrum works in 95% plus people in my hands too, so without anything fancy on top. So I would say the chances of having any significant clinical instability on the lateral side with this approach are minimal, if at all.
Yeah. Okay, and I think that's where we'll end this. Thank you very much for joining me. This was brilliant. As always, I always learn so much from you both, and I hope everyone else out there will learn a lot from this too.